Okay. So the last talk is on how to improve our decision making and how we decipher dysfunctional lens index and depth of focus in various cases
So
based
just go to
on
slideshow, sir.
eye trace. I've done it. Okay. Okay now.
Yeah.
All right. So So what is this dysfunctional lens syndrome? This is a term described by George Beringford way back in 2013, and he divided this into uh, three stages. Basically, in stage one, it is basically akin to presbyopia, where the lens is clear and colorless, but it becomes stiff and the ability to accommodate becomes much less. And stage two happens when the lens start turning little yellow. It happens between 50 to 60 years of age, and there is slight blurring of the vision. It affects the vision by affecting first the night vision. That is the first sign of cataract. And the stage three is when the visual acuity goes down beyond below 2025, and it also patient has a obvious cataract and with or without glare, and it involves visual impairment. So what we have, how we can diagnose this dysfunctional lens syndrome on the eye traces, we have a dysfunctional lens index score on the software of eye trace, and it has a scale up to 10. The number 10 means the lens is clear and there is no opacity. Lower number means there is some dysfunctional problem in the lens, which could be based either on higher order aberration within the lens, and it also relates to the contrast sensitivity and the pupil size. So coming to different example, this is the patient display of dysfunctional lens. In this, you can say the corneal, this is a post-LASIK patient, underwent LASIK around 10 years ago. He is around 42, and his cornea is fairly okay, but his internal aberrations are high, and the DLI index is 4.6. Anything more than 5 is usually taken as normal. Less than 5 is taken as maybe a cutoff point for surgical intervention. But if you see the tracy reflection, it is in red. It is not because this is not reliable, and it is because of very high internal aberrations. And if we see the lens opacity index, it is just zero point 0.5. So it is the dysfunctional lens index, which is maybe grade 1. And we can show this display to the patient to make him understand, and this may become a candidate for clear lens extension or refractive lens exchange. And this is another patient. Again, here, if you see the opacity grade is 2.5, cornea is okay, quality of vision, but the lens index is 6.61, and the reflection is in green, and it means the whatever dysfunction is there in the lens, it is because of the refractive changes, and it doesn't need a surgery as of now. But if patient has some symptoms, then they can undergo surgery. And this is another patient, similar patient. Here the cataract is very minimal, zero point 0.5 grade, and index is also quite high, near normal, and the reflection is in green, but here angle alpha is more. So maybe later in life, we may choose to do not a multifocal. Time and again, we have said the role of angle alpha and kappa, and maybe a aspheric uh, Hoya, or a non-aspheric or aspheric neutral IOL. And this is the same patient with high angle alpha, and you can see hardly any internal and corneal aberration, and the spherical aberration is very low. But as of now, there is no need to do a surgery. And this is another patient. You can see here the cornea also is symmetric bow tie, and the quality of image from the corneal aberration is also not as good, and the internal opacity grade is grade 1, and the dysfunctional lens index is very low. And here angle alpha is in the yellow range, and the tracer refraction is also not very reliable. So we may counsel this patient for the cataract surgery, but we have to explain the corneal aberration to the patient, and we should avoid multifocal IOL in such cases. And this is another case where the DLI is very low, 0.72, and the rate of the opacity is 2.5, and you can see the internal aberrations are also very high. Angle alpha is good, so this is a good candidate for doing any type of IOL or cataract surgery. And it has been shown in various studies that a 10 is a perfect score for a clear lens, and it's 0 in dense cataract. And the DLI, there are other ways of measuring the lens opacity like lux or classification or on a pentacam, but the DLI had a stronger correlation with the corrected distance of visual acuity, and it's more sort of dependable for knowing the opacity. Uh, this is a very interesting patient. You can see the cornea is good. There's a very minimal opacity, but the internal aberrations are very high, and the reflection, as you see, is not dependable because of the higher order aberration, and the total eye simulation of each chart is very disturbed, and you can see very high comma as well as spherical aberration in the eye, which are mainly internal. And when we went back to the slit lamp examination, you see patient has a lenticonus with minimal opacity. So main cause of his bad vision is lenticonus leading to coma and spherical aberration. And now coming to the measurement of accommodation in this patient, we have this available in this eye trace. We ask the patient first to focus near, then at distance, and the difference map gives us the amplitude of accommodation in these eye. This can be represented in a 3D map like this, and this is the for near, for distance, and the difference of two gives us the amplitude of accommodation. And coming to the depth of focus, this is not my slide, I borrowed it from Rosha's talk. This shows uh, amplitude of a, this is a true pseudo accommodation. The difference between the two peaks, here it is taken by asking the patient to focus for the distance. The blue is for the near, and this is for the distance. And this is a true pseudo accommodative lens like a crystal lens, and this is the two peaks. So the patient has a true pseudo accommodation of 2.19, and the available range is to the tune of 3.17. But last two slides, and this is my own patient. She has a very borderline DLI, and the tracer reflection is reliable. She has minimal angle alpha, and but she was very miserable. She's sister by profession, working in PGI, so she wanted to get her cataract out. She had this corneal spherical aberration of 0.29, and we could choose any other. There's no contraindication for doing multifocal. Angle alpha is good, as well as kappa is good, and we put in a SIFI multifocal DO of IOL in this case, and this is the uh, defocus curve, which we charted manually. It takes a long time, almost 1 hour, to chart this defocus curve manually by doing it in the optometry department. But iTrace does it in just 2 minutes. We ask the we take the iTrace with the near focus and with the distance focus, and we can see the difference between the two peaks is just 0.5. That is true pseudo-phakic pseudo-accommodation, but the range of defocus is almost 3.91, which is this is a pseudo-accommodation, which is because of the DOL. So the eye test gives us a quick assessment of defocus range of different IOL, which is very handy. Otherwise, doing it manually becomes a very time-consuming procedure. So with this, I'll conclude my talk, and with this, I think we can throw open the instruction course for any queries or